We're going to start the fireside chat component of the symposium. And I just wanted to start by saying thank you very much to everybody who's here. This is a historic event, this symposium. And we have Tracy Glynn and Steve Staples and Pauline Worsfold to thank for the fact that we have all of you in the same room. It's absolutely, it is totally a blast to meet you, to hear from you. As Frédéric Chabot was saying, it's really inspiring. And people who didn't know each other now know each other. For example, I've had the pleasure of meeting Jane Philpott, who I've admired from afar for quite some time. So my name is Anne Lagacé Dowson. I'm the comms person at the Canadian Health Coalition. Just to remind you, the Canadian Health Coalition in itself is an achievement. It's a cross-section of experts, healthcare workers, unions, civil society, and nonprofit groups, as well as individuals. And it was founded in 1979, 5 years before the Canada Health Act was passed. And it played a key role in getting the law passed. And the idea of the coalition is to advance public single-payer universal healthcare. So a big thanks to all of you for coming, answering the call, and showing up in this lovely space today. And at my side, of course, is Jane Philpott, family physician for 40 years, former member of Parliament, first doctor to be Minister of Health, who went on to Indigenous Services and the presidency of the Treasury Board, who spent 9 years in Niger in West Africa doing humanitarian work, and speaks a little bit of Hausa and pretty decent French. And she is now the director, you are the dean of the Faculty of Medicine and Health Sciences, pardon me. So now in academia, newly minted author, did a master's degree in public health policy. So talented and accomplished. It's a bit mind-boggling. So welcome to our symposium. You're our closing act, Jane.
Thank you.
No
I am
pressure.
very happy to be here. Thank you.
So you wrote this book, which I read and marked up and obsessively pored over. It's called Health for All, and we're going to offer you the possibility to purchase the book and have it signed by Jane after we're finished talking. While you're imbibing, this will be your opportunity to purchase the book and go home and study it, because it is a memoir. It's a policy document. It has so many interesting elements in it. It's a very enriching read. It's entitled Health for All, A Doctor's Prescription for a Healthier Canada. So that word prescription has come up again in the context of this book. And I'm just going to start with a quote that caught my attention when I was reading it. It's in the introduction on page 7. It drives me mad when I consider that 6.5 million Canadian adults do not have a family doctor or any other access to primary care. Unless we act soon, it will only get worse. Our population is growing rapidly in some provinces. The average age is rising. The health workforce is not keeping pace. It is insupportable to go on like this. Access to healthcare has been a long-standing core Canadian value. It would be foolhardy to walk away from that value now. We can still work together to bring our health systems back from the brink. So that is the tone, or the way in which the book is launched. And it lines up completely with what we're hearing today from so many of you, both in the panels and at the microphones. So when you say it drives you mad, I mean, I wonder, you came to medicine out of a vocation for social justice. So tell us a little bit about how you came to be a doctor in the first place.
Well, first of all, thank you very much for having me here. And I am really honored to be at this historic gathering, which maybe we'll all look back at someday when either the CHA 2.0 or the Canada Primary Care Act or whatever the next iteration turns out to be, we'll look back and say, remember that day when we really started to take this seriously again? And we'll remember this gathering. So when did I start? I actually started medicine early. I was I probably went into medicine before I actually knew what I was doing, except that I had a desire to be a public servant in a way that I could spend as much time as possible trying to help people be healthier. And medicine seemed like the obvious way to do that. But like many others in the room, eventually discovered that it takes more than just a medical degree for people to be healthy. And my learning about medicine continues to evolve.
And at one point in the book, you quote Rudolf Virchow, who says, medicine is a social science and politics is nothing else but medicine on a large scale. politics is nothing but medicine writ large. That's later in the book. And I think there's a lot of truth to that. So tell us a little bit about the prescription you've cooked up. What is a primary care home?
Well, Robert was just up here saying hello and told me that, he's completely aligned with my prescription. And I agreed with him that I am absolutely not the first person to have come up with this prescription. I admit that openly in the book, that the kinds of things that I'm talking about have been talked about for decades. There are, I think, a few new features to it. It is essentially doing the unfinished work of Medicare, the work that Tommy Douglas, Monique Bégin, and others have been calling for a very long time, to ensure that our commitment to access to care includes comprehensive primary care and care delivery from a set of providers that is well beyond physicians. And why it drives me mad that we haven't done this is that other countries have done this, and what we are asking for is not an impossible dream. It's a dream that is the reality for people in a number of countries, particularly in Europe, and there is absolutely no reason, apart from political will, that we can't do this in Canada. And so the vision is to have and I'm sure this metaphor, I haven't heard it here today, but it's been shared widely, the concept that just as in every neighborhood in this country, there is a public school for your children to be able to attend elementary and secondary school based on your geography, we should have in every neighborhood in Canada, based on your postal code, access to a primary care team. And when I say that, I don't need to explain to this group that it is the integration point for both health and social services, involves obviously access to clinical care, but is also the place where you'll have your housing supports, your mental health supports, your home care links, your palliative care links, etc. So I think the vision is probably fairly widely shared here. What I hoped through the book, a couple of things around talking about legislation, which hasn't been talked about to the extent that it ought to be, but also to take this in the spirit of Michael Rackless saying, we need to gather everyone together and rebuild the coalition. This was written, I had in my mind my 88-year-old mother, who's a very smart woman, but doesn't know anything about health policy. And I had in mind that I wanted to write it in a way that my mother would understand health policy and be able to have people across this country who don't normally think about the laws and policies of health, to be able to say, yes, we should be able to do that, and then be able to talk to their politicians and others about it.
So this model that you talk about has been put into place. It was tried in Ontario starting in 2002 under the title Family Health Groups, Family Health Organizations, Family Health Teams. In Quebec, they are called Groupe de Médecine Familiale. I belong to one, luckily for me, in Montreal. So I go to a CLSC and I have access to nutritionists and all kinds of wonderful caregivers in that one-stop shop. Now, it has been dramatically underfunded and undermined, but it still exists in Quebec. So it has been tried and it has seemed to be successful. So tell us about why it didn't take hold.
So I would say variations on the dream have been tried, but no government has ever said we are going to implement this for every single person who lives in our province. And so, I think the efforts around primary care reform in Ontario that were started in 2001, 2002, could have had the potential to get us very close to this. It was never, the capitation model for physician remuneration, I think, had a lot of unintended consequences, in large part because it was never, it never became universal. And those who started to examine its results in the early days determined that those who were already advantaged were the ones who were most likely to be able to have access to teams.
Capitation means money?
Capitation means paying doctors according to the size of the panel of patients that they agree to care for. But unless you aim for universal empanelment, if that's not a very nice word, but unless you actually agree, you meaning the government, says that we are going to ensure that every person who lives in this province has access to that primary care team, And in the case of Quebec, most of those group médecins de famille are still largely physicians, is my understanding. So it's not truly interdisciplinary primary care in most cases. But those were some of the closest examples of how far we've ever come, but it's never been implemented universally, nor has any government seriously committed nor legislated for universal implementation.
So you talk about something called the periwinkle model. I wonder if you could touch briefly on that. That's the ideal model that you describe in your prescription.
This was an effort that was, we were frustrated in the Kingston area, which is where I live now, with the fact that none of the primary care models to date have been perfect, and perhaps there never is a perfect model. Family health teams and the remuneration models that underlie them. We've seen a little bit of movement around nurse practitioner-led clinics. Probably the closest examples across the country that have been successful have been community health centers, but community health centers have largely only been accessible to marginalized populations. They've not been envisioned nor delivered in a way that allows capture for the entire population. So we actually had one of a nurse practitioner who started one of the first NPLCs in Ontario, as well as myself and a few other family doctors and some folks from our local community health center and hospital and Ontario Health Team all come together to say, look, let's actually write down what's the best thing about every one of the models that we're in, toss out the stuff that doesn't work in the models that we're in. And what we came up with is a model that we've called the periwinkle model, which is supposed to remind you of a beautiful 5-petaled flower and therefore remind you of the quintuple aim of healthcare. It's essentially a CHC, but a CHC with a plan that you would have a CHC in every single neighborhood. So that's the easiest way to explain it.
And what do you respond to Michael Rackless, who says he has to go visit this one particular care facility where what we should have is actually happening? Like what would you say to him?
I would say I agree entirely.
I should all go probably, right?
Well, I've had a chance to visit the model. I've had a chance to be up in Alaska and see the incredible work that's happening there. And it is probably the best model I've ever seen in North America. And while we can't, I don't know why it's, not enough people have been able to implement that more broadly. I say in the book, it's political will. And I was there as a politician, but I didn't manage to get back. I think it was during the time when I was with Indigenous Services that I went to see the NUCA model, and it's fantastic. NUKA, look up the NUKA model in Alaska. It's superb.
NUKA. I'm gonna go look at that later. So you spent 40 years as a practicing doctor in various capacities. You also worked with Syrian refugees, and you worked with people from Ethiopia. You worked in HIV/AIDS. You worked with MSF. You did COVID care, emergency COVID care in your neighborhood, and you worked with Iraqi refugees. So yours is a quest not just for Canadian healthcare, but for global justice. And I wonder, what is it going to take based on your travels and your many experiences? We talked about how people have to be mobilized. Here we are at the Canadian Health Coalition trying to bring people together. What is it that is going to mobilize people?
It's a fantastic question. And I think Michael Rackless described it exactly, is that it's going to take a grassroots uprising of Canadians saying, when the politicians knock on their doors, we want 100% access to publicly funded primary care teams, and we want them to be in every neighborhood. And we know that other countries have done this, and we know that we can actually do it for less money per capita than we are spending now. So please make that your number one campaign promise. And I'm super excited that CFNU has invited me to be part of their I'm not sure if I'm supposed to tell people this, but I get to talk to all the premiers in July. I'm so excited about it. And I'm going to challenge them, as I did through the book, but they may not have read my book yet. I want one of those premiers to run on a platform or one of those who will run against them to run on a platform where they will say, we are committed to making sure that every person in our province has access to primary care. I think there are some provinces who have a chance to do this. I know that notice there's some folks here from both Nova Scotia and New Brunswick, and I think they are probably the closest to being able to get there. And there's certainly a movement, a health home movement happening right now in both provinces. So that's really encouraging. I think there's some encouraging moves from Wabkanu in Manitoba. I'm not sure that he's got the vision yet of 100% access to primary care, but Canadians need to ask for it. Politicians need to commit to it. They need to realize they're not going to do it in 10 years, but they need to stake their future electoral success on whether they get a serious start.
So friends of mine who worked on the Canoe campaign described it as a healthcare campaign. He is married to a physician. The Manitoba Health Coalition was very involved in the campaign. Many of them have now gotten jobs inside the new Manitoba government. So there's some considerable potential. So I hope you give them hell when you're talking to them, the premiers. I really do, because it is a source of despair for so many people. The 6.5 million you described who can't get primary care, who wind up in the ER and wait for 12 hours. Some of them just go home.
Well, it's not
It's
just the 12
shocking.
hours, it's the fact that they're showing up in those emergency departments, being diagnosed with end-stage cancer, for which they have had symptoms sometimes for months and have not had any other place to be able to turn. And it is stupid from a financial point of view for us as for the public system, but it's absolutely unconscionable from an ethical point of view that people are dying prematurely because of lack of access to care.
So what about the Canada Health Act 2.0? What do you think that would be?
Well, I've been in and out a little bit today. Is this being taped? Can I watch the stuff later? Yes, thank you. Okay, that's very good, because everything I've heard today has been amazing, but I have missed a few of really excellent presentations, and I will look forward to watching all of it. It's been really great to hear the conversation. Really want to commend I loved the talk about Canada CHA 2.0. I've had this debate with Colleen Flood for some time where she has always said we need to open up the CHA and do the amendments there. And I have always argued from primary care that I think that there's a rationale for having a sister act. Honestly, in the end of the day, I'm not sure that it really matters which of those pathways we follow. I think there's a case to be made for either one of them. But countries that do have 100% access to primary care, for the most part, have embedded that in federal legislation. They have embedded a right to primary care. And I think that that's what we need. The ideas are not new. What has stopped us from being able to see them delivered is that that it has not been embedded in legislation. And I think the CHA proves to us that with what is a relatively simple piece of legislation, you can actually embed some national principles or national standards and build in the accountability mechanisms.
In the book, you describe healthcare as being like your former cottage, Windermere, I think it's called, where it was once a glorious log cabin, and over time it deteriorates and it starts to become compromised, and then it starts to become maybe a bit dangerous, and you can't cable it together, and something needs to be done. So can you tell me a little bit about the analogy that you make between the falling down cottage, much loved but falling down cottage, and healthcare?
Yes, and there's a funny story behind that, because I was just trying to formulate this. I like to think in metaphors as much as possible to help people kind of imagine what's possible. And I happened to be writing some of it while I was at our cottage on Big Rideau Lake. And literally the week after I suddenly this metaphor clicked, Andre Picard wrote an article comparing the healthcare system to 24 Sussex Drive, and he used almost exactly the same metaphor. I'm like, darn, Andre always beats us, right? But anyway, so I thought I'm going to go ahead with it anyways, with my version of the metaphor of the crumbling cottage that's falling apart. And the point is that, you know, sometimes as things are crumbling, but they hold enough of cherished memories and values to which we're attached that nobody wants to tamper with them. But at some point in the day, someone has to make a decisive action to say, we have to actually do something differently here. And and in the case of our cottage, which we eventually sort of took down all of the outer walls and rebuilt it, we retained this beautiful old stone fireplace in the middle and then rebuilt it on the same design, but so that the walls would not fall over. And I think that's what we need to do potentially with the Canada Health Act or a version thereof, is to say, let's retain the principles. There's nothing wrong with any of those principles. I don't think any of us would change them. Some would argue we would add one or two, and we would redefine them and strengthen them. So let's retain the values of Canadian Medicare, but we need someone to have that decisive action. I would like to see a federal politician and a federal party or two actually make that decisive commitment that this is time. It's been 40 years. We have a whole lot of deferred maintenance on this act, and it's time to get it done now.
And what about people who say, oh, no, if we open that up, the enemy will be inside the castle walls and it will all come crumbling down?
I don't think there is a precedent to propose that would suggest that would be true. So, you know, it has stood the test of time for 40 years. It will stand the test of being amended. We have lots of other pieces of beloved legislation that can stand the test of amendments.
Somewhere along the way today, somebody expressed hope that Mark Holland could be the minister who could potentially be a guy who could spearhead something like that. And I wonder how you view him, having been the person in that seat and having dealt with people inside of the department, some of whom are here and who we admire greatly. I wonder how you would view that. You can choose to not answer, of course, Madam former Minister.
So Bill Thole and I have been debating this a little bit over the last couple of days when he sent me an advanced version of his paper. I think this is that kind of decisive action that we need to build the movement with the political energy to be able to do this work. I worry about the exact current version of, and you know, is this going to be broadcast to like the whole world?
No. Well,
I am not
how you
sure
define the whole world, I guess.
I am not sure the federal government in its exact current form has the political energy to do this. That's not to say it couldn't come along in the months ahead. I'm going to maybe be a little bit circumspect in what I say, and you can ask me my thoughts on this when I'm not being recorded.
Okay. But it's possible to imagine that the energy could be injected, because I think I heard someone else refer to the fact that we have about a year between now and a potential election call. So it is possible to imagine that could ignite.
I think we're going to see my prediction is that we will see some political surprises over the next 18 months, and that neither the federal or provincial elections are going to be when we expect them to be. And I'm speaking to the Ontario provincial election. There'll be some surprises, I think, in the next 18 months. My general sense is that for something of this magnitude, if we're going to do it right, you know, CHH proves to us that you can do it in the dying days of a mandate. I think it has to either happen in the dying days of somebody who's like, we're going to do this and like mic drop, I'm out of here, you guys run with it, or it's going to have to be in the very early days of them where that's an electoral mandate that a government or a coalition government potentially actually cobbles together and says, we told you we were going to do this, and now we're going to implement immediately upon forming government.
Because it occurs to me that if you are sort of on the skids, because that's what the polls are saying about the current Liberal government, that maybe this is the saving grace that could possibly get them reelected.
It is possible. And if they have the ambition to do that, I would be absolutely delighted.
Andy Longhurst talked about the forces arrayed against the idea of public universal health care as we have it in Canada. The insurance companies, big pharma, there's a lot of people who really have their eyes on the profitable capacity of the healthcare system. How do you view the forces arrayed against us when we talk about universal single payer healthcare?
Well, I think, you know, I've heard it discussed already in the room a couple of times, the power of medical associations. all eagerly anticipating who's going to take on I don't think anybody's heard who's the new president of CMA is going to, or the new CEO of CMA is going to be, have we? We heard? No. Okay. I suspect we will hear soon. That may be an important announcement who that happens to be. We've had some pretty strong leadership from the presidential side of the CMA, which I think has been helpful. In Ontario right now, we have really good leadership in our provincial association, some of the best leadership both at the chair, president, and CEO level that I have seen in a long time. So I think those kinds of things are in our favor, that we have leadership of some of our medical associations that's I think motivated by the right things. But the bottom line is, and Monique Bégin is the one who said this, and I remember her discussing this with me. I tell the story in the book about the moment when Pierre Trudeau crouched down beside her and talked to her about, how are things going? And she was really worried. And he said, who's for it, who's against it? And she said, the doctors are all against it, but the people are for it. And he said, well, then basically it's a slam dunk like the Constitution if the people are for it. But the other thing she told me in her personal, she doesn't say this in the memoir, but she may have said it to others. She said the nurses are for it. And, you got the people for it in general and the nurses for it specifically, it'll be a winner. And I think that those are the people we need to get on side again.
Well, I know that some of the nurses are very upset about what's happening and what they're being forced to deal with. In Quebec, the nurses in the FIC, the union that is the biggest nurses union, they are the only people who haven't signed an agreement with the Quebec government, which is very unusual. And I know Pauline can attest, I've been to some of the CFNU meetings. People are really frustrated about overtime, about any number of things. And so I think maybe that is a source of strength. I think the healthcare workers unions are amazingly powerful and far-seeing. And some of them are represented here today, for which we're very grateful. So I think you're onto something there. I'm interested in hearing a little bit more about what you think about the role of doctors, because they seem to be ambivalent at best and hostile at worst to change. I mean, starting with the doctors' strike in 1962, the doctors' strike in Quebec in 1970. How do you convince and build something like the wonderful group called Canadian Doctors for Medicare? How do you bring in more physicians? And you've also talked a lot about recruiting GPs. You've worked and had some success at that. Seems like the GPs are probably the most progressive group of doctors. Is that possible?
It's hard to put the personalities and motivations of physicians all into one lump. I think probably dangerous to do so. I think there's a real spectrum in terms of what motivates people, why they are doctors, what they care about. I've thought a lot about this since I've been Dean of Health Sciences and Director of the School of Medicine. I think we have some work to do in terms of admissions and recruitment to medical school and what characteristics we're looking for in future physicians. We've actually made some really interesting moves at Queen's lately to change our approach to admissions. That's not going to have an impact for a while, but I'll tell you a really funny story. This is just show you how naive I am. I did not actually understand. I was a doctor for literally 35 years before I realized that not everybody went into medicine because they want to help people get well. I don't know where I missed that along the way. I wasn't paying attention, but now that I'm the head of an academic medical organization, AFP, alternate funding program, I realize that there are actually people there that are motivated by different things than I am. So that has been insightful.
The same thing about politics too, that you didn't realize until you went into politics that there are people in politics who really just want to sabotage certain kinds of initiatives. They're not actually trying to make the country better or improve things or work with each other.
Yeah, that's probably a slightly different story, slightly different kind of.
I was shocked by that too when I ran.
Say, I refuse to give up on physicians in general. That at their heart, most of them see it as a vacation, vacation. Sorry about that. A vocation. Some of them see it as think about vacations, but most of them do
vacation
see it as
homes.
a
Yeah.
vocation. I think we need to increasingly talk about that amongst physicians. I am committed to increasingly talking about that amongst our young physicians and medical students, that you are at the end of the day a public servant. Your role here is to serve people. You are publicly funded, and we need to think about what we owe back to the public for the incredible privilege of having what is probably the most secure job in the nation. And we owe it to the people of Canada to primarily focus on the service of those people.
On that note, I'll just say, long live Jane Philpott and physicians of her ilk, and long live all of you. And I really hope that this will galvanize you and encourage you, because there's so many of us who see the need and want to be helpful and admire each other's work. And now some of us know each other much better. So I hope everybody will stay in touch. And thank you for your patience. It's been a long day. It's been like a long graduate seminar, packing information into your heads. You've been absolutely wonderful. And thanks again to Tracy Glynn and Steve Staples and Pauline Worsfold and Jason McLean, who's no longer here. But a super heartfelt thanks to all of you, the nurses and all of you, and Jane Philpott for being so frank and so candid.